nice to see both the chairpersons and the speaker. They are all from PGI Chandigarh. And first of all, I was just seeing the poster, what's new in pediatric anesthesia. But my topic is almost reverse, history of pediatric anesthesia. That means what is old in pediatric anesthesia. But I must dilate upon that new residents who have joined anesthesiology, they must know the past. Because most of the heroes, pioneers and inventors, they have worked very hard in shaping our specialty, anesthesiology as well as pediatric anesthesia and its subspecialties. Now, at the beginning, these inventors knew that there is a difference in anatomy, physiology, and functional development as compared to adults and the children. And pediatric surgery has operating a child will carry a high mortality, and between 1700 to 1800, almost 100 years, nobody has touched the pediatric patients. But lately in 1846, when Morton experiment and his administration in Marsden Hospital, he showed in a public demonstration that we can give anesthesia which is painless, patient remain immobile, and there is a good recovery. So there is a fascinating anesthesia history over the last more than 150 years. And the question is why we should study the history of anesthesia. In fact, I am touching history, and Dr. Kapi has very well said the 21st century of pediatric anesthesia, where he has dilated upon the ultrasound guided blocks, neurotoxicity, pediatric pain, and so many issues related to day-to-day life that we are facing these days. The question is, we must know our past, and if we know the past, then we can always depend on our future and improve upon it. But more importantly, the history of surgery is linked to the development of techniques, particularly our techniques which we are using. And history of surgery always follows the history of anesthesia. That's important. Whether surgeon may or may not agree, but it is true. And we are all part of it. It's, as Dr. Kabir has said, that it's a team effort. So in the past also there was a great team effort, with the result that most of our heroes, they have worked very hard in shaping this specialty. Now this slide in fact is a duplicate because Dr. Kabir, our pediatric surgeon, he has already discussed about the various drug methods and non-drug methods which were used. In fact, they were used to create anesthesia, and the results were very poor. There was a lot of morbidity and mortality, and by doing nerve compression or carotid compressions, though there will be less pain, but patient usually die in the post-operative period or in the post-surgical era. Then came this, Dr. Kabir has shown some other slide. I'm showing this slide that this is barber shop surgeons at that time. And most of the surgery was done in terms of amputations and dental extractions. And, but there was no antisepsis. There was no infection control. And a large percentage of patients, they die following surgery. So what changed? I think change is basically because most of the, you can say, botanists, physicists, zoologists, or other pharmacists, they were operating these patients. And they are assisted by sometimes parents of the boy, of the girl. And they have seen that the patient is in agony, distress. So we should change and adopt some measures which will give us some painless surgery. So that changed the whole scenario. And then came an important contribution by Dr. Venus. Now, they have seen that in Bristol there was a pneumatic institute, and they have seen three gases: nitric oxide, carbon dioxide, oxygen. But these gases, they are meant for anesthetics that we are using these days. But somehow they were given, are being inhaled in way of some medicinal diseases like headache, cold, fever, but not for painless surgery. Until Humphrey Davy came. He became superintendent in this pneumatic institute, and he recognized that if you give analgesia, it's painless for the patient. And later he renamed as laughing gas. So there is a lot of contribution from Davy. But he stayed till that day. He didn't use N2O in surgical patients. But that was his remarkable discovery and his impression that N2O is an analgesic gas. And then 1844, that means almost 150 years later, Horace Wells, of course, he pulled tooth and with the help of N2O, but somehow he couldn't demonstrate in Mass General Hospital. And later on he got depressed. So why no anesthesia until 1846? Reason was that there was hardly any concept for anesthesia. And at that time it was considered that surgery is almost lethal. So there was no attempt of doing surgery. And of course these gases were used only for medicinal purposes. Now, evolution of pediatric anesthesia started very late. If you go into stages, there are 4 stages. In stage 1, you can say there is a control of pain, immobility of the patient. Then later, very late, 1940, it becomes a specialty by itself. And then there's a further growth, and now 21st century, there's so many advancements in pediatric anesthesia that now we see very less morbidity and mortality. Although in 1846 we started anesthesia, but there was a first documented letter by Long. He anesthetized an 8-year-old boy for toe amputation in 1842, but somehow he couldn't spread this news to other places. Until this fellow Morton, he gave a successful demonstration in 1846 in Boston, and then says, we have seen something today that will go around the world. So that was a discovery which we always say, Anesthesia Day in 16th October 1846. And then the first edition of Lancet, Dr. Bigelow, who was there in that Mass General Hospital, he wrote a letter to Dr. Boots. He was in Boston at that time, that this discovery has occurred. Surgical operations performed during insensibility. That was the title of that letter. That was a letter written by Bigelow to Booth. And then the thing spread to various countries. So ether spreads via the steamer. In 1846 it has gone to UK. where the ether was given to many patients in 1846, although there was no documentation, but most of the classic work has been written in various books. It was also said that it is a safe, and it is easy to use, but most of the time the surgeon used to give this ether anesthesia, or nurse, or even patient's attendants, or even parents. In fact, the first report of pediatric anesthesia came in a book which is written by Robson, where there is a mention of ether anesthesia. And John Snow was the first person, 1 year after Morton's this public demonstration, that ether was appropriate for these pediatric patients. Then came the discovery, simultaneously there was discovery of Simpson. He used chloroform, particularly first for obstetric anesthesia. And slowly the chloroform became popular after his article in Lancet in 1847. He wrote that the baby was obliged to inhale. He snored. And then it was a painless procedure. And the baby woke up after some time. This was written in Lancet in 1847. That is second edition of Lancet. Then came a very popular figure, John Snow. He was known as father of anesthesia. And this was his largest series, 147 infants. And he did in 1857, where 98% of the patients they survived. Of course, he gave chloroform to Queen Victoria for her 8th child. And also John Snow, you know that he classified the various signs of anesthetic depth, and there the Goodell's classification came into being, from surgical analgesia to the medullary paralysis, which we see with ether. In fact, to administer ether, when I started in my house job practice, and many senior colleagues they have given it, you can judge the various stages of anesthesia. Previously it used to be called an art of providing anesthesia to a patient, to a child, but I think it is both art and the science. To provide ether in a child is not so easy without monitoring. I could see the pupillary response, the carotid pulsation of the aortic pulsation, the color of the child, and the respiration. These were the four principal monitors that were seen by the anesthesiologist, and there was no monitor at that time. And there was no mortality. Although we have seen so many patients have hyperplexia in the recovery room, 1 or 2 patients have convulsion in the recovery room, all things happen, but later on they recover very well. The first death was reported in 1848, which was attributed to chloroform, and that was published in the paper, Death of a Child from Chloroform. After that, chloroform went into disrepute, and the safety of chloroform and ether was being challenged. And it was known that chloroform causes hepatotoxicity and dyslipidemias. In fact, in 75, the father of pediatric anesthesia in North India, Dr. Pritam Singh was there. He used to demonstrate how to give chloroform in adults at that time, and we used to see a lot of dyslipidemias. Out of 10 patients, 2 had dyslipidemias. And at the same time, we were giving oxygen to the patient. So, chloroform has its own implications. So, it has also gone into disrepute. So, 2 factors contributed to chloroform's evolution. One is, of course, hepatotoxicity, and then came the introduction of ethyl chloride, very rapid induction agent. And this superiority was shown by Dr. Wade. He wrote, I have come to the conclusion that it is a drug of choice, at least in children under 13. He said it is up to 13 years of age. But it was given in the adults also. So various methods were used at that time, and the most popular method was use of Schimmelbusch mask. This is a German guy who introduced it in 1890. And nowadays also, you will see that it is on the examination tray when DNB or MD candidates appear in it. Many of the old examiners, they always ask, what is this mask? It has a drainage tube where you can pour out the excess of anesthetic agents. So open drop ether became very popular, and ether chloroform was fading out and ethyl chloride came. Then various masks were available, and in fact they were written in Dr. Lee's book, who is a very popular figure in pediatric anesthesia. Then of course natoxide came very late, 1847, although it was invented in 1700 almost. And Colton reintroduced it, natoxide. And then nitoxide cylinders, they were available in UK in 1865. And in 1880, so many transactions were done, if you see the literatures. And first specialty of pediatric, that is pediatric orthopedic specialty came into existence. What were the type of monitoring they were seeing? Only they were seeing the strength of the pulse, whether it is weak or it is having bounding pulse. There was no monitor at that time. You can see here in this picture. This was first book, Lee's, where they have seen that venethin and ethyl chloride were safer for the maintenance of anesthesia. So, new era in pediatric anesthesia came when ether was replaced by halothen. So ether was outdated, out-fashioned in 1955. And then came the invention, that is sepsis, antisepsis. This is germ theory, and you can see two paintings. In one painting, Dr. Gross, who was a surgeon, who was operating with street cloths. While another painting, after 18 years, when the germ theory came into existence, he started using gloves and the apron. So there lies the difference between giving antibiotics and not giving antibiotics in patients, because they were doing amputations, squastectomy, osteomyelitis cases, amputation of toe, all these things. Then they were starting giving some antibiotics. Although Dr. Kabir has already discussed spinal anesthesia, but there is no doubt that if you go through the literature, then in Chennai, spinal anesthesia was given in children. But August Beer, who was the first person who started in long time back of use of cocaine, and Abha Jain was the person who has started popularizing this method, and he said that after giving spinal anesthesia, there are no postoperative complications. But at that time, the only needles were used, these hypodermic needles, and there were no spinal needles, which are now being used these days. Then this is the first change, that is introduction of cycloprine. Many of the senior colleagues must have given cycloprine. I think it's a wonderful drug for induction. Patient sleeps within seconds, though costly, though inflammable, and may cause some signs. A patient goes into apnea very fast. So that was used for small infants and poor risk patients. The further progress came in pediatric anesthesia is use of various masks, oropharyngeal airways, and at that time closed circuit, adult closed circuit were used for pediatric patients, though there were some innovations in that circuit. The first great step which has replaced ether is the use of muscle relaxants. That came in 1942. There was a big history how it reached in the anesthetic era, but at that time most of the surgeons and the anesthetists, they were using oxygen, nitoxide, and some inhalation agents, but no ether was given. So that has almost replaced it because of the invention of general anesthesia. Halothen was first used in 1956. At that time, people have seen there is a lot of dysrhythmias, hypotension, bradycardia during inductions. So there came the era of monitoring. Precordial stethoscope came into existence because of this halothen. And then we have a consolidated stage, and then various societies have been formed. And these are some of the pioneers, we must know it. New must know the old. That is Robson, he was considered the father of pediatric anesthesia. When I go to a hospital for sick kids, I have seen a big picture lying in Dr. Lerman's office, who was the head of department at that time. I am talking in 96. So he was considered, and he started using he was using open anesthesia in 1930. Then everybody know his contribution towards pericardial following succinylcholine. He has written a paper also, and he has published a textbook on pediatric anesthesia. Phillips array, we are using this circuit. Almost he invented this circuit in 37, still we are using it. And his discovery is paramount. Then Rees modified RSTPs, and in fact, he described CPAP method where you can improve on the patients who is having respiratory or highly membrane disease. In fact, he formed a committee, and this was the first committee, an association of pediatric anesthesiologists and Great Britain and Ireland. This was the first committee which he formed. Then this is a very important discovery by physiology of the newborn infant. Then new techniques came, particularly newborns or newborns. And this was a remarkable recovery, and he has written a book also. APCOR, everybody knows, everybody using till today, 1 and 5 meter per score. What is assessment and how to take care of these newborns, particularly at the time of resuscitation in the operating deliveries. Lang was the first person, she is a nurse, she was a nurse, and she gave anesthesia, tracheostomy fistula, and PD ligation. She was the first lady to provide anesthesia to Dr. I think Lads was a surgeon. Everywhere, not only in the operating room but also in the neonatal resuscitation room and various MRI where pediatric cases are being done. And then slowly the tubes have been replaced. We have used coal a number of times. There are a lot of advantage, but somehow it is abandoned because of leakage and some treacle damage. Of course, Randall, Baker and Soso were 2 persons, and they have introduced this mask. And then there is a discovery of first generation, second generation, and now third generation of laryngeal mask airways. Hansen is considered as the first lady who provided a deep hypothermic cardiac arrest and anesthesia in the hyperbaric chamber. And most of the pediatric cardiac anesthesiologists, if you read these books, her name is always mentioned. Then 2 discoveries came. One was use of fentanyl air oxygen for ligation of PDA. This was a very important contribution by Dr. Gregory, who was an anesthesiologist. And he said that in order to prevent the stress response, we must use high fentanyl. Then everybody knows that KJS Anand, he was in US, first in UK and then USA. He wrote almost a dozen papers on the role of neurochemistry, neurophysiology, neuropharmacology of stress in newborns following cardiac surgery. And his papers, after his papers and his contribution, fentanyl became very popular. Then the next recovery came is treatment of idiopathic respiratory syndrome. And again by Gregory, same person. He used CPAP. In fact, Kennedy's son, he was suffering from this highly membrane disease, where he was given CPAP and he recovered. Then 21st century, we know that Dr. Kabir has already discussed. We have so many developments as regional ultrasonography, hemodynamic monitoring, robotic surgery, simulation for particularly those students who are doing fellowship program, and then fetal and surgery and exit surgery, and so many techniques which have come on, all because of anesthesia improved over a period of time. There is a better recovery and the morbidity and mortality is less. Simulation good for making advanced skills and judgments. Then and Dr. Kabir has also discussed these two papers. This discovery that short-term anesthesia doesn't cause neurotoxicity, although he has said clearly that repeated and long-term anesthesia can cause neurotoxicity, but still two studies are important. Till now there is no evidence, but follow-up is going on a longer time. Then fellowship program by IPA has been started. In fact, now there is a DM program in pediatric anesthesia in KEM hospital, and almost more than a dozen institutions have fellowship program. PJ has one. They are doing under the chairperson of Dr. Neet. They are doing fellowship program in pediatric anesthesia. And then we wrote an article by Dr. K Rao. Dr. Kabir must be knowing. He is a very famous personality in India, Dr. K Rao, who retired recently. And we wrote an article that in order to save newborn babies, we need more pediatric anesthesiologists. This editorial came in Indian Journal of Pediatric Surgeons. See, still we remember ISTPs, it has come in 21st century. In 1937 it was started, and now still it is there. So some old things are still there in the 21st century, although ether, halothane, cyclopropane, chloroform, they have vanished. Curare has vanished, but new things have arrived. But RSTPs is the one who is still there in this 21st century. So finally I can see the future of pediatric anesthesia and our children's is assured, but we have to see our roles and how we practice it. It might change. So this is a museum which is in Illinois in US, and it gives history of anesthesia and its specialties, and there is online material also. And I think if somebody goes to Illinois, he must go to this museum of anesthesia and learn about the past. Thank you very much for your patience hearing.
Thank you so much, sir. We have come a long way from Schimmelbusch to robotic surgeries, and but the main thing which stays is patient care, safety, and clinical monitoring. It still is important.